Um, and please, you are welcome to share your additions and then the omissions that I'll be making. Thank you. The epiglottis is a epiglottitis is a life-threatening inflammation and swelling of the epiglottis that can rapidly obstruct the airway. Okay, the epiglottis is something that lies above the larynx. Okay, and it serves as a protective um, structure. Okay, it prevents us from aspirating the food we eat. It makes air flow through the right channel, and then food also flows through the right channel. So it sits at the back of the tongue. Okay, and it is always above the larynx, like I said, serving as a cover, and then it's in front of the esophagus. So imagine this: anytime we are talking, the epiglottis closes the esophagus so that our voice box, which is the larynx, because it's sitting on top of the larynx, okay, it helps us with our voice as well, okay, because it is sitting on top of the larynx, like I said. But when we are eating, it closes the larynx and then it opens the esophagus of the trachea, the larynx, and then to the trachea, so that we are not to aspirate the food that we eat. So that is the function of the epiglottis, okay, preventing us from aspirating and all that. So anytime this epiglottis is inflamed, inflammation sets in and it becomes swelling. It obstructs the airway. Like I said, it is sitting on top of the larynx. So the moment it increases in size, it becomes an obstruction to the airway. Okay. So it is a flap of cartilage located above the larynx, like I said. Normally it closes during swallowing to prevent food from entering the trachea. And then when it's inflamed, it can swell enough to block the airflow, like I said. So let's look at some of the causes of the epiglottitis. So historically, the most common cause was Haemophilus influenza type. So we know when we go for weighing, when the kids go for weighing, there's this 5-in-1 vaccination. I usually call it DPT hip pep, DPT diphtheria, pertussis, tuberculosis, and Haemophilus influenza type B. So initially, this was the most common cause of epiglottitis. But because now we have the vaccination, okay, it is not rampant like it used to be. Other causes include the streptococcal infections, the staphylococcal infections, viral infections, burns from hot liquids, especially the ones that you have covering the person's face and throat, okay, and then airway trauma, and then foreign body injury. So these are some of the causes of epiglottitis. Now let's look at the pathophysiology. We all know that whenever there is an infection or injury, there are a whole lot of things that goes on, okay? The moment there is infection, you see RBCs rushing to the area, the muscles going there, the area getting swelling, there is redness and all that. So when there is injury or infection to that side, the epiglottis, sorry, becomes inflamed, like I said. Then you see this severe edema that will develop, making the airway narrow, okay? Because it is taking space there, it makes the airway narrow, and then breathing becomes difficult because the airway has been completely obstructed. So you see patients struggling with breathing. So anytime you hear of epiglottitis, remember the epiglottis has been inflamed, and because of its position, it is impeding airflow. Please, let's look at the signs and symptoms. Uh, sorry, let's look at the assessment findings first, sorry. So with the assessment findings, we'll have the person drooling. The person will have stridor. There'll be fever, difficulty swallowing, muffled voice, and then the tripod position. Okay. A person will be drooling because of the inflammation there. The person has difficulty of swallowing anything that comes in. because the person cannot swallow, automatically those things will now tend to cut. Even the person's own saliva or secretions, okay, the person cannot swallow them. So this person will open the mouth and you see whatever secretions drooling out from the person's mouth. And because of the obstruction in the airway, you'll be hearing this stridor sound because the person is trying to breathe, even though there is an obstruction there. There'll be fever and there'll be a muffled voice, okay? The muffled voice because, like I said, the larynx is helping us, is bringing our voice out. But once there is a problem around it, now the voice is not able to come out well, like it's not able to sound like it's supposed to sound, and you hear this muffled voice. Okay. And then the tripod position. This is how it looks like. With children, they often sit leaning forward with their chin thrust out, their mouth open, and their tongue protruding. And this is what we call the tripod position. And they do this because it helps maximize airflow. When they do this kind of position, they are able to breathe better, either than sit like the way we all sit or relax in a bed. When they do that, they struggle with the breathing. So this position helps them to sit better. And with the elderly, you will see that it's either they are sitting on a bed or on a chair at the edge of the chair or the bed with their hands or their arm leaning on their chest or resting on their chest and in that same position, okay, like they are bending, they are not really bending, but you see their chin thrust out and also their mouth open, trying to get in some air into their system. And if they are not sitting, they are giving this bending position or squatting position, the same thing with their hands and their head, trying to get in some oxygen. Please, let's look at the diagnostic test. With the diagnostic test, so it looks like with the diagnostic test, we will perform, that one is performed only when the airway is secure. We have the lateral neck x-ray, which may show the TAM sign. The swollen epiglottitis resembles a TAM. So the picture you are seeing is because that sign over there, you can see the, is it the I don't know how you mention it, but you can see the epiglottis trying to, you know, get close to the uvea, okay, because it is inflamed. It is giving that term sign. It is swollen, and then when the person opens the mouth, you are able to see it. Ideally, you are not supposed to see it, okay? You are supposed to see only the uvea and then your tonsils and then straight to the back of the esophagus. But because that epiglottis have been swollen, sorry, now you tend to see it and it's giving you the term sign. And that is an indicative that there is an inflammation of the epiglottis going on.
Hello, Sarah. Sarah, can you hear us? The rest of you, can you hear me?
Yes.
Yes,
You can hear
please.
me. Okay, so Sarah, if you can hear me, um, close everything and come back again like you did before, okay? And I don't know whether you had a call or something. So it's happening again. Okay, so as we are waiting for her, I just want to do some small touches, okay? I don't know whether she's going to talk about it. Remember when she was talking about the assessment, okay? But before that, let me put a question here so that you think about it. When she's done with the presentation, I'll ask you differences between epiglottitis and croup. Okay. If she doesn't capture it, That is what we look at. So that when you get like these study questions and they start mentioning um, patient appears to be leaning forward or sitting down, drooling, there is stridor and all of that. I mean, what you should think about. Okay. Remember, sometimes, you know, when so this one even takes me back to the question our sister asked before. Was this Sarah? Because I think Sarah who had the same question. Let's say you have a new Q bank, you've not studied much, okay, you are doing NGN, and it gets to a time, let's say you are doing a case study and they ask you, you are caring for a patient or a nurse is caring for a patient with injury at, let's say, C4, okay, at C4. Maybe the injury resulted from motor vehicle accident or something. Yeah. So the patient had motor vehicle accident and had injury to the fourth cervical, like let's say C3, okay, C3, and they ask you, or let's say they continue to add up. Let's say patient is now having headache, okay, patient is now having goosebumps, severe sweating, all of that.
Yeah, please, your
The
voice
trick
is too down.
is my voice down.
Yes, please.
Oh,
Well, not really
No,
at
his
our
voice
end.
is okay. Oh.
kindly increase the voice at your end, okay? I mean your volumes. Kindly increase your volumes too. I'm trying as much to increase mine, so try and let's see. Okay. All right. So let's say if they tell you patient has injury, let's say C3, okay, C3, and they tell you patient is now having severe sweating and all of that. Okay, severe sweating, goosebumps. As soon as you see these three things in any case study, before you even come to a conclusion, at least you have an idea of what is happening. You know that um, what is happening is likely to be what autonomic dysplasia before you even come to look at what is being asked. Okay, so that is one great thing about knowing some of these things. Remember, there was a time I told you whenever you get questions and they ask you, let's say the case study question is talking about things like forty sputum or pink tinge sputum. Okay, 40 FROTHY 40 sputum or pink tinge sputum. About
Yes.
99.9% of the time, it's always pulmonary edema. So some of these things you don't need a miracle before you can figure out. Okay, yes, you don't need a miracle before you can figure out. So some of these tricks, just learn them and keep them in mind. So you see how she is presenting it. There are some signs, even though when she's done, I'll go through, but you'll see. Sarah, you can try and share. You are so close. You can try and share your screen again. Let's see. Okay. Okay. So like how she was presenting it. When you see things, well, I don't want to jump into it. I wanted to finish before we go through those things. As soon as you hear or you see about three cardinal signs, at least you should start thinking about epiglottitis. As soon as you see them, start thinking about what epiglottitis. Let me just mention them, just in case. Um, I mean, I think she's still trying to join. So we have something, some people have come acronym with it, okay, like 3Ds. As soon as you see drooling, dysphagia, okay, and distress, like respiratory distress, okay. some will even call it DDR, like drooling, dysphagia, and respiratory distress. You can call it 3Ds. Okay, drooling, dysphagia, and distress. The distress is more of what? Respiratory distress. So as soon as you see these things and they tell you infection, remember, what did she say the causative organism was?
Influenza.
Influenza B.
Which one?
Influenza type.
Hemophilus influenza type.
Hemophilus influenza. Good. So if you see these three main things, and you have this drooling, dysphagia, and the respiratory distress, you should just look that it's likely to be to be a epiglottitis. Okay. Yeah, Sarah, can you hear us? Okay, still trying. You can see your screen, but we can't hear you. Okay. So those are the things. And remember, because it's an infection, because it is an
Please, I can
infection.
hear you. Can you hear me?
Yes, I can hear you now.
All right, thank you. Please, can you see my
Because-
screen?
Yes, yeah, you can carry on.
All right. So I'm sorry for the break. So with the pathophysiology, I was saying that the infection happens, and you know what happens to an area when there is an infection? Automatically, the place will become inflamed. There will be edema, and because of the location of the epiglottis, the airway will be narrowing, making breathing very difficult because the airway has been obstructed. Okay, and then finally you have a complete airway obstruction, which may occur. I missed a slide, which is the signs and symptoms. Okay, and I heard Borgia talk about it. The 3D. Those are the classic sign of epiglottitis, which is the drooling, the dysphagia, and the distress. And I was explaining the drooling. I was saying that because of the swelling, okay, the child is not, or the adult or whoever is infected with the epiglottitis is not able to swallow his or her own secretions, okay? So the person automatically opens the mouth, and then whatever secretions that is in, like the way we swallow our normal saliva, will tend to come out. And that is how the dysphagia is because of the swelling and the inflammation going on. It's painful, so it makes swallowing difficult. So that is why we have the dysphagia. And the distress is the respiratory distress, okay? Because of the airway narrowing, the person struggles to breathe. And that is how come they assume the tripod position. So that the classic signs are the 3Ds, the drooling, the dysphagia, and the distress, which is the respiratory distress. But the other findings are the high fever, the severe sore throat, and then the muffled voice. The muffled voice can also be known as the hot potato voice. They tend to talk like there is this hot food in their mouth. So, when somebody is talking and you see that sound like there is something hot in the mouth, that is the kind of voice that they have. Then they have stridor, they have anxiety, they have tachycardia because they are trying to compensate with the oxygen flow. They have restlessness, retraction, and then we have cyanosis as the late sign. And then with children, like I said, they often to sit in a tripod position, like this, leaning forward with their chin thrust out, their mouth open, and then their tongue protruding. This one helps them to take in air more effortlessly. So please, having said that, the diagnostic sign, like I was saying, and I was saying that it's only performed only when the airway is secure. Okay, you understand where we get to when I say the airway is secure. We'll come back to that. So you do the lateral neck X-ray, which may show the term sign, like I said. Ideally, when you open your mouth, like for that you're seeing that is almost touching the uvula. We are only to see the tonsils at both ends and then the uvula. We are not supposed to see the epiglottis. We are seeing this because of the inflammation. It has swollen up and is pushing out of its normal position and is coming up so that we can see. So anytime you see that sign of the 3 days, then you know that there is an epiglottitis ongoing. With the nursing priorities, I was saying that we all know since the airway is being obstructed, the number one priority is the airway, our ABC. So you remember ABC, you know we have to check the airway, and then nothing is more important than maintaining patient's airway. With the nursing intervention, we are saying that because the tripod position helps them, okay, assume because it helps them to take in oxygen, we are supposed to calm the child down because the moment the child is crying, whilst you are crying, then the oxygen demand too will be more, and then you'll be having that distress. So because of that, we allow position of comfort. So if the child or the adult in the tripod position is comfortable, please let them be. Do not tell them to lie down or assume a position that you think is helpful, unless it is not getting air in. But the moment they are assuming that position and it is helping them breathe, please let them breathe. Then next, we administer our humidified oxygen if necessary. So the child is in that position or the adult is in that position, but your oxygen saturation is bad, you can administer oxygen. And then we monitor for the respiratory status as well, as it is improving or declining. Because the airway is so important, prepare for intubation. Okay, prepare for intubation. So whilst you are doing your assessment, you've already prepared for intubation so that if the case exaggerates, okay, or exacerbates, you then intubate the patient. Then you keep emergency airway equipment nearby, like I said. Always remember to keep emergency airway equipment nearby. Then we start IV antibiotics since some of the causes are bacterial infections, like I said, there's staphylococcal and the streptococcal infections. Okay, these are things we are not supposed to do. Do not inspect the throat with a tongue blade. Okay, so if the throat, do not take a spatula, the one we use for oral examination. Do not inspect the throat with that because the moment it comes into contact with the epiglottis, the swollen epiglottis, there's this spasm that worsens the whole case and puts the patient into severe respiratory distress. And do not force the child to lie down, like I said. If they are comfortable in the tripod position, please let them be. Children are so glued to their parents. When you separate them, they are coming to cry. Now that they are coming to make all the noise that you know, and that will further worsen their condition because they'll be struggling with airflow. Okay, and do not agitate the child just because we don't want this child to be crying so much to impede airflow. With the medical treatment, we talked about antibiotics. Okay, examples like the ceftriaxone and then cefotaxime because it's a bacterial infection and bacteria can cause that infection. We give them antibiotics. And our airway support, our oxygen, our endotracheal intubation. And in real cases, we go as far as tracheostomy, okay, if we think intubation and all that is not helping. Or if we cannot keep endotracheal intubation on for a long time, we can do the tracheostomy. And then we give our IV fluids. Remember, nothing is going down there because of the swelling and the pain that the patient is going through. Patient is not taking his or her over, so we will have to compensate with IV fluids to keep the person hydrated and also not to run into hypo. And the IV is used when swelling is difficult, okay? With the key and clear spells, we are saying that epiglottitis is an airway emergency. Think epiglottitis, think epiglottis, think the location especially, and think that it is on top of the larynx and it is an airway emergency. Know that during like the 3 days, which is the during the dysphagia and the respiratory distress, plus the tripod position, you think epiglottitis. You never use a tongue depressor. You keep the child calm because we don't want child to be crying. We prepare for intubation. Airway is always the priority. High fever is common. The muffled hot potato voice is also a classic sign. Remember the position of the earths. And then the thumb sign may appear on the lateral neck entry, which indicates that there is a swelling of the epiglottis. Okay. So we'll move on to the croup, but differentiated from croup, you know that drooling and tripod position favors glottite. The backing of
Hey,
the croup.
who is
Thank
that?
you. If you allow me, I'll move on
So,
so we can
Sister
compare the
Sarah,
two.
someone is making
Sister,
noise in the
Yes,
background.
sister.
we didn't hear someone is making noise. We didn't hear the last part. The last part
Sorry,
you
I
were
can't hear. Please come again.
the last point on your slide. Somebody's background was making noise, so I didn't hear what you said.
Oh, okay. So I'm talking about the ankle spells.
Yeah, the last point on the ankle bells.
I was saying that I'll quickly go through the group so that we can differentiate between that and then the epiglottitis.
Oh, okay.
Yeah, I'll let you continue with that very soon.
All right.
Because
So please wait.
that was even my next question. But anyway, I'll let you do that. But before,
Please, can you see?
yeah, we can see. Before you go on with the group, I just want you to also know that some books will tell you we have 4Ds. Okay, some archives will tell you we have 3Ds, like the one we talked about, drooling, dysphagia, um, respiratory distress, right? Or distress, yeah.
Yeah.
With the muffled voice or the hot potato voice that Asista said. Another word for it is dysphonia. Okay, Dysphonia, dysphonia. So when you see 4D somewhere too, it's still the same, which is also a classic sign. Okay, so I don't think anyone here should get
Okay.
the epiglottitis question and get it wrong because she has explained to us that there is tripod assumption of the patient, there is drooling, high temperature. Thought about these four things if possible. As soon as you see three of them, it is easy for you to think or to catch them. Sometimes in a funny way, how we say it, no, I've catch you. I've catch what they were trying to do, or I mean how they were trying to trick me. You have to catch them so that you can answer correctly. Okay, so it's my prayer you don't forget. Keep it once and for all. The things are plenty already. Okay.
Mm.
Then with the before she starts with the group, if you have any question with the epiglottitis, ask before we move on. So before Mr. Jane, your hand is up. Before you ask your question, remember she said what not to do. Those are the areas ankles tricky on. Okay, what not to do. So the ankles will present itself in a way that, let's say the patient has come to the hospital. We want to examine the mouth. Okay, can we just go ahead and examine the mouth? I mean, the back of the throat. Can we just examine it?
No,
No.
not
You can't use tongue blade.
you can't put anything.
Okay. So do not even make an attempt to visualize the truth. Like I mean, in all, sometimes they not even tell you using a tongue depressor or something. To reach that part, but they will just tell you maybe a nurse trying to visualize the truth. that sentence alone is also wrong enough. So don't always wait for something that we are putting in there. Trying to visualize. How do you try to visualize it? Without securing the airway, when you try to visualize, it could also block the airway. Okay, so don't try. As soon as you see these signs that we've mentioned, the 4Ds with temperature, think of what particular title. And it's a respiratory emergency, medical emergency. Straight away, you make sure you secure you are not waiting to be, but they are going to ask you for. So intubation to secure the airway before assessment, like thorough assessment. Okay. Mr. Jane, your question before is a bit please.
Okay, thank you. Please, I want to find out two things. Number one is about the tongue. We are not supposed to put in anything. So, how is the intubation done? Is it that the
Okay,
child is
okay, so with intubation, just even imagine without epiglottitis. How do we do intubation? Intubation, we have everything on set. Okay. We have resuscitation, it's everything on set. At the end of the day, before we even put a tube into a person's trachea, we sedate the person and we paralyze the patient. And the patient will not be manually breathing. Almost, most of times, okay? We sedate
Okay,
patient and paralyze before we tube. And that is for a short while because we have everything in there to take over the patient breathing. So it's similar. Do you understand it?
okay, okay. So, please, I just want to understand. So it means that sedation is done, the intubation is done. After that, that is when you go and do your x-ray and then you see the count sign, right?
No, when someone comes to the hospital, most of the times
Mm,
X-rays and those investigations as Sister mentioned, they are the first things you do. Okay, they are the first X-rays, or maybe if they recommend it, maybe next CT, you are going to see what is
mm,
happening there, and plus the signs that the patient is showing, you will see those things, and physicians will most likely treat patients before they can go ahead and clear that, but they will not open their mouth. They know. Okay, they will not open their mouth and put in a time pressure to visualize the back of the throat before they decide to.
okay.
You get it. So all those things they are done if
Mhm.
it's an emergency, they are done at the emergency. If they are done at walk-in like OPDs, all those tests will be done for. But if the physician or the healthcare provider suspect epiglottitis, they themselves they know, everybody knows, so they will not attempt to do that, especially if unprepared. There are no intubation kits. I mean, you are not ready. When you do that, and there's no way blocking. How are we going to manage that? We are going to do the patient
Okay,
in the shortest possible time. So, you know, the signs are enough, plus the scans that will be taken. Then they will show. You will see it there.
okay. And please, last question. Does it mean that if so you said the intubation is for a short while.
Oh yeah,
Um,
just to manage it, and it's per patient outcome and per physician's discretion. If they start treatment and I mean there's a reason, most of the time they'll take repeat scans and all of that. There's a reason for resolution of the epiglottis, like the inflammation has resolved and I mean
mm,
everything is fine. The patient will be extubated. And if antibiotics have to be continued at maybe at home, the patient will be discharged with antibiotics and that's all. It is
it
the
it
it is an emergency and it is onset. Like I said onset. It is what's the word? I'm looking for the word. It's like sudden, yeah. Like
acute.
sudden, yeah, it's sudden, acute, good. Those are the words I'm looking for. It happens sudden, it's not like a gradual thing. Okay. So at the
Okay,
emergent point of it, you protect the airway, then when you start treating and everything de-escalates, you can take the airway protection from there.
Okay. Okay, I think I
Oh,
understand. Thank you very much. But there's not always fever, right? It depends on the causation,
There's
right?
likely to be fever. There's likely the chances are more than 50% for epiglottitis. Chances of
Okay,
fever, they
because
are they are not they are not like 50-50. The chance is more than 50% of fever.
okay, because I saw that with the causes, she mentioned there could be trauma. If it's just trauma, is there going to be fever?
Like trauma as a cause of epiglottitis.
Yes, except I
Um,
didn't see right.
no, he said no. We are saying the main. Okay, so traumas are special cases. Okay, they are
Okay,
special
thank you
cases.
very
Yeah,
much.
yeah, they are special. It's not if it's not infection. No, it's the infection that will generate the fever.
okay. So are we
Yes, boss.
giving
Thank you.
NSAIDs?
Like NSAIDs as part of the
The
treatment.
treatment, yeah.
What do we think? Let's think about it. NSAIDs in the hospitals. I'm sorry, in the hospital. Okay, normally, remember I've said this in live class before. NSAIDs are discouraged because of other risk factors. Okay, other risk factors. So for treatment of pain, generally, okay, yes, I mean someone just typed analgesic. NSAID is also a type of analgesic, and acetaminophen is also analgesic. But NSAIDs particularly, well, maybe for pain, but between NSAIDs and it's not a direct contraindication though. But between NSAIDs and other analgesics will be fine than NSAIDs. NSAIDs are mostly discouraged because of the side effects they come along.
Okay.
But it doesn't mean that it's a contraindication. Okay.
Okay.
Yes.
Thank
And
you.
Mm.
remember this patient is PET NPU in the first place, right? So if anything, like if there is any analgesic or something, it should be more of IV. But NSAIDs are not actually contraindicated, but they are just discouraged, you know, they're just discouraged. Between whenever you get questions between NSAIDs and unless maybe the NSAID is used to do something. I mean, I think I think we have some NSAIDs, they are used as is it tocolytics? If I remember my ops and gynae role. Ibuprofen. Ibuprofen can be used as is it tocolytic?
And
But
indomitable.
indomethacin group, they are all NCs, right? So you see, they are used in special cases, but just for pain, I mean, it's difficult. I don't know if you understand what I'm trying to say.
Boss,
Yes.
I was thinking that we said it is an inflammation, and
Mm-hmm.
this anti-inflammatory medication.
Mm-hmm.
That is, I'm not the one that asked the question, but that is what is coming to mind. That since it is an inflammation and we want to
Mm-hmm.
reduce the
Yes, that was why I
inflammation,
asked the question.
yeah, that's why we are
Okay.
choosing the
Bonjour, please can you hear
anti-inflammatory.
me?
Okay. So like I said, they are not contraindicated. They can be given if but remember it's nothing per oral, right? In the initial phase, MPO is what NSAID is not contraindicated in management of type. Maybe for um for maybe fever, right? And for pain, that is fine. But if you have any most of the time if you have any other analgesic that is not NSAID. For me, that's what I'll go in for. NSAID management of pain,
Bonjour.
yes, management of pain is something small when it comes to croup. But the fevers between acetaminophen and NSAID, it's better to if you see Tylenol or acetaminophen, always go for acetaminophen. If we are treating fever and there's no acetaminophen, you can go for NSAID. That is fine. Okay, but between the two, I mean, always go for acetaminophen. But in a nutshell, NSAIDs are not priorities. That's what I want to say. Yeah, someone will take it.
Bonjour.
Yeah,
Bonjour.
is it Sarah? Sarah?
Yes, please. I
Okay,
wanted to address the
okay,
first two questions. I wanted to add my voice to it.
okay.
So with the causes, I made mention that the Haemophilus influenza type B is the primary cause. Okay, that is historically that has always been the cause, coupled with the other infections, bacterial infections I talked about. With the burns and then the injury and the trauma, think about it as a secondary infection, okay? Because if with a trauma, for instance, let's say there is an endotracheal intubation ongoing, an endoscopy ongoing, or repeated throat suctioning ongoing, there is damage to the epiglottis. We know that inflammation comes about when there is a barrier that has been broken and a bacteria has find its way to invade, and then inflammation develops. Okay, so the trauma doesn't cause a direct problem. Okay, but it is a secondary problem. You breaking the barrier of the epiglottis and you getting bacterial infections to invade the place, and that is how come you get a trauma or an injury to become part of the cause. Just like the burns, like I said, when you have someone having the burns around the face and then the neck, automatically that barrier has been broken. Okay, so you are looking at a wound around the throat and it is a deep wound, and you are having all those structures there, and a bacteria can invade that place. That is how come we have hot the burns and then the trauma and injury becoming a cause. Okay. And our sister asked of the fever. There's one thing I have noticed. I haven't been in the ward for some time. All my life I have been in the theater room, but for the short moment I've been in the pediatric ward, I've noticed that with children, when they have infections, especially bacterial infections, and you start your antibiotics, within a span of 48 hours, you are likely to see a drop in the fever. Okay, sometimes you can give all the acetaminophen, you can do ibuprofen plus the acetaminophen plus your antibiotics, and you will still see the fever persisting. You can choose to do only antibiotics for 48 hours, and you have the temperature coming down. So I'm trying to say that because it is a bacterial infection, once we start our antibiotics, I assure you within 48 hours, you're likely to see the temperature dropping. And like our sister said, since we have NSAIDs to be a non-inflammatory drug, you can also give your NSAIDs to also beat the fever down. Thank you.
Okay, thank you. Thank you very much for the addition. Are we all okay now? Hussein,
Okay,
Yeah.
boss, thank
So
you very much.
okay.
Hello. So please, I
yeah,
think
Hussein
one
side
of
was up.
our yes, I think one of our sister was trying to link the fact that since we say NSAIDs are anti-inflammatory disease, probably maybe we may use the NSAIDs in treating the inflammation. But then I think
No, 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 no. The inflammation is because of the infection. You can't,
exactly,
yeah, it's not a priority. The priority
exactly
is I mean, to treat the direct infection is to target the positive
the
organism,
positive.
antibiotic. Yeah.
Exactly.
Any other question from anyone?
Because yeah, doesn't mean the primary focus is to combat infection and
The
clear
primary cause is
airway.
infection. Yeah. Itis inflammation caused by the positive organism there.
So the primary focus here is to combat infection and clear
Good,
airway.
good. But when it comes to infection in the airway, remember airway because you know let us get this clear. It is infection that is happening. Okay. If let's say it was an infection of the hand, antibiotics will be the priority. But over here it's infection of part of the airway. So when it comes to even between antibiotics and airway securement, which one do you think you will choose?
Airway.
You choose airway. Okay, so you protect the airway first, then your second priority will be the treatment of the infection. Okay, because of where the infection is. If let's say it's just a cellulitis or something, your first thing will be what? To give antibiotics. That will be your priority intervention. Is are you getting the difference? Because you will need time to treat infection, but airway you will not need time. That is why airway becomes your most priority thing. Even though it's an infection, but airway protection is your priority. And your second priority becomes the antibiotics for treatment of the infection. You will get it.
I was, yeah. Please, when epiglottitis, she didn't cite the age group.
The what?
When the epiglottitis, she didn't cite the age group.
The HB. Are you talking about the hemoglobin?
Age group.
Epiglottitis.
Oh, okay.
Yeah.
This is Sarah.
Please.
Can you hear us?
Yes, please. It's most common in children, like 2 to 7 years. Okay, but even after the hip vaccine, you can have adults around age 20 to 50 years who will also be exposed.
Yeah, anyone at all can get. But it's more among like
It's more
pediatric
among children age 2 to
children.
7.
Yeah. Okay. Kindly complete this one with us so that we can go. Okay. Let's carry on.
Okay, please. Our next, it's really heavily. I don't know if you can hear me. Our next topic is the group, but that is a
Okay.
viral infection
But you
that
can
also.
hear you. Okay.
It's also a viral infection that also causes swelling of the larynx, the trachea, and then the bronchi. And with that one, it usually affects children 6 months to 5 years. And the common cause is the para-influenza virus infection. With the pathophysiology, the virus finds its way into the airway and inflames the place. There is swelling below the vocal cords, which is the larynx, from the larynx down to the trachea to the bronchial. And this narrows the airway because of the swelling. So the person has difficulty breathing. So with the croup, think of the airway right from the larynx down to the trachea to the bronchioles being swollen, and then you have a barking cough. Okay. With the clinical manifestations, the classic sign for it is the barking or the sea-like cough. Inspiratory stridor, that's when the person is taking in air. The hoarseness of voice, low-grade fever, respiratory distress, and then retraction. So with the group, we have the classic sign to be the barking cough, okay, which is always permanent, the respiratory stridor, hoarseness, low-grade fever, respiratory distress, and retractions. And then the symptoms are often worse at night. The diagnosis, we see a staple sign. That is what the X-ray will show. I wanted a picture, but I was late. So the tracheal narrows like a chest staple. It's just like um something like a staircase, but just picture the trachea and it comes bump. I don't know how to. When I get a picture, I'll show, please. So it narrows like a chest staple, and then the ankle stip we know for that is the staple sign for croup. With the management for mild croup, the goal is to reduce airway irritation and then keep the child comfortable. So we keep the child calm and quiet because crying increases the airway swelling and then the breathing difficulty. Then we provide humidified air or cool moist if prescribed, and this may help soothe the airway. We encourage oral fluids to prevent dehydration and help pain secretions. We monitor respiratory status and then we watch out for increasing stride or retractions or the breathing being worsened. Then we allow the child to rest. Medications. Every mouth group is often treated with a single dose of corticosteroids. Corticosteroids such as dexamethasone. And this helps reduce airway inflammation and then can prevent the symptoms from worsening. With moderate to severe cases, we give corticosteroids like the dexamethasone and then the prednisolone. Please, we know that anytime we are dealing with corticosteroids, we think about is it 8X? So please have that in mind. And then the purpose is to reduce the airway swelling. With severe cases, we are giving racemic epinephrine, sorry, and it reduces airway edema rapidly. So that one is used for severe stridor. And please, after administration, we have to monitor closely for rebound airway. With the nursing priorities, this one to the priority, the number one priority is the airway, since we are dealing with the airway, the passage of air, which is the larynx, the trachea, and the bronchiole. So we want to monitor for increased stridor, retractions, restlessness, and cyanosis. And our expected findings are the barking cough, the hoarse voice, and the stridor. Okay. With the teachings, we want to encourage fluids, we want to keep the child calm, and we want to avoid crying so that we don't increase the oxygen demand. Please, this is a differences between the croup and then the epiglottitis. With the causative organism, the croup is viral, and then the epiglottitis is usually bacterial. The onset with the croup is it happens gradually, and the epiglottitis happens suddenly. With the fever, we have low-grade fever for croup, we have high-grade fever for epiglottitis. With the croup, there is a barking cough, and the epiglottitis is usually absent. There is no drooling in croup, but there is a drooling in epiglottitis. With the voice, we talked about the muffled voice, which is the hot potato voice in epiglottitis, but we have the hoarseness of voice in croup. The position with croup, they don't need any special position, but the epiglottitis need a tripod position. With the X-ray, we see the staple sign for croup and the thumb sign for the epiglottitis. Treatment for croup, we need steroids and then epinephrine. With epiglottitis, our main focus the airway plus antibiotics. Croup is usually not an emergency, but epiglottitis is an emergency. While we want to look at the similarities between both can have stridor, both can have respiratory distress. We have retraction in both. There is always an upper airway obstruction. There is hypoxia because of oxygen demand, and there is a need for airway monitoring. For both, remember that airway is the priority. Thank you.
Okay, thank you very much, Sister Sarah. Thank you. You're doing us a nice presentation. I think the little I wanted to add, she later touched on all of them. So if you have any question here, you can ask. Raise up your hand so that we can see you. If you have any question here. Any question? All right. Even though it's raining at the end, but she's been able to do that for us. Thank you. Thank you. All right. If there are no further questions, we have already spent.
All right, so we are starting maternity nursing today. And before we start, I have some few questions to ask you just to prepare the way, all right, for maternity nursing. And if the class should be participatory, we just have to involve ourselves mute your mic if you're not talking. If you want to talk, just raise your hands and I'll call you to ask or contribute. Okay. So that is what we are going to do today. So there's a question before us, which states that a nurse is preparing to perform a non-stress test for pregnant client at 38 weeks of gestation. What equipment should the nurse gather for this procedure? Select all that apply. So we are performing non-stress tests for pregnant women. What are the equipment that we need? A is reclining chair or bed. B is a belt with 2 transducers. C, a paper strip or a computer screen. D, a button for the client to press. And E, an acoustic stimulator. What do you think are or is the answer? What do you think is or are the answers? Yes. Any idea? Yes. Mr. Linda. Mr. Linda Pash. Can you please come in? Mr. Linda, can you hear me? Okay, Sister Linda, maybe the mic is on, but can.
Hello, Sir Frank.
Yes, please.
It's A, B, and
Okay.
C.
A, B, and C. All right. Reclining chair or bed, belt with 2 transducers and a paper strip or a computer screen. All right. Any other?
Please, I would go for A, B, C, and D.
You go for
A, B, C, and D.
okay, Sister Forgive. All right, A, B, C, and D. Eliminating a button to press. Okay, Sister Abigail, don't pray. Sister Abigail. Sister Abby. Okay, she's still, maybe she'll come back. Sister Bana, therefore.
Sir. I will go for A, B, C, D.
A, B, C, D. All right. I have some comments here. Okay, Sister Abigail says ABC, Sister Cynthia, Sister Rhoda, Linda, Sister Beatrice. Okay, thank you all for. That's what I want. If you can't speak, you can just share, type it, okay? Is someone talking? All right, so let's see. Non-stress. With non-stress, that is B and C. We use a belt with 2 transducers. You know, chair is lying, using a reclining chair or bed is not part of the actual thing that we need. Okay, it's not a thing equipment that we need. All right. Because patient can use any. All right. And a reclining chair is not the ideal thing for this patient. Ideally, what position should they assume if you are doing this kind of procedures? Yes. For pregnant women, what position is best for them?
Left lateral.
Left lateral.
Left lateral.
Left lateral. Okay, it's best. Left lateral is best for them. Okay, so for chair or reclining bed is not necessary. And a button to press, a button for the client to press. That's mostly used. You commonly give a button. Do you give a button to patient to press when there's a symptom? Which procedure is that? When you're doing what?
Contraction test.
Contraction test. Okay. So if we are, is someone talking?
Yes, please.
All right.
Yes, I want to come in like for the button for client to press. I think I recently had my baby, so I got um I had a button to press. They gave me one to press. Yes, when
What
they
were you?
for
What
the
was the procedure?
non-stress test and pregnancy non-stress test. Yes.
Non-stress.
Yes. So I was sitting up. I was like the reclining chair, almost like a reclining chair. I was sitting up usually, and then I will have a button to press when there's a contraction, when the baby is moving. Yes. And the nurse will monitor.
Did they give you anything?
Yes, they gave me a button to press. So when
any medication to take, anything like that?
No, they didn't give me anything to take.
How was the procedure? Can you please describe it?
Okay, so I would be given a seat to sit in the reclining chair, and then I'll have a belt that is around my belly. Yes, then they'll have to hold the what is the I forgot the name to hold the monitor that what is supposed to be attached to my belly in place. So when it's attached to my belly, they hold it in place with a belt, and then they'll give you a button to press when the baby starts moving, so that you prompt the nurse that the baby is moving. I think when you press it, it shows on the machine that the baby is moving, and then they want to compare both with what is on the computer, so that they know that actually the baby was moving or something. So you have your button to press, and then you have your strip around you, that thing, the belt around your belly. And then I was always sitting up. Yes, whenever it was, yes, a reclining chair. So I'm a little confused, a little bit confused with. I don't know if it's
But
different
Frank, I
elsewhere.
also got the same thing. I was sitting. I didn't lie down. I was sitting in a reclining chair. So I
Yes,
think
yes.
it's a reclining chair.
Okay, that's a nice experience. But the thing is that reclining chair is not like, if you take away reclining chair, we can use any other. It's not something that is automatic. I hope you get my point. It's not that we need reclining chair by all means. No, we can do away with reclining chair. Patient can assume in left lateral position, and we can still do the procedure. Are you okay with me? So reclining chair is not like automatic equipment that we need before the test can be done. Are you okay? Yes, Sister Jane.
Yes, we are okay. I think we are okay.
Sister Jane.
Please, Yes, good
Mm-hmm.
evening. Please, I just want to find out. It says a reclining chair or bed. I have not done the non-stress test before though, but then I just want to find out. You were saying patients can assume the lying position, that's the left lateral, or can sit. Apart from these two, can the patient assume any other position for the test? Other than that, I am looking at the one. If a patient has to be at one place, sit or lie down, then that is what I'm thinking, that the chair or the bed will be needed.
Okay. Sister Ruth.
Okay.
Sister Ruth.
Yes, sir.
Mm-hmm.
The reclining chair can be a bed and the same time can be a chair. So you can adjust it to any position you want, either sitting up position or lying down position. Or sometimes some people, their own, you can turn it in lateral position. That's how those beds, that's how those chairs are.
All right.
So I think it's part.
What I'm saying, you're not getting my point right.
Mm-hmm.
Can patient without reclining chair, let's assume without a reclining chair, just a normal chair. Okay. Can that one be used?
No,
Why?
because you cannot adjust the normal chair into these positions they want. But if they say reclining chair, it's a specific chair, not any other chair.
Before that, let me ask you, with the non-stress test, what is the test being used for? Is it about the movement that they want?
They want to know how the baby is
The
doing.
baby,
How the baby what?
the baby is moving or how the baby is doing.
No, it's done to
No,
check.
that is not. You are missing this procedure. You are all missing this procedure. Non-stress
Yeah.
test doesn't show how your baby is moving. That's not what we are assessing. To change positions.
Okay.
It's done to check
Yes. Is that to do what?
heart rate or what?
Is that what? Please come again. Someone was talking, please. Come again.
Is it not to monitor the baby's heart rate?
All right. I've gotten, is it not? There was one lady at the discussion group. Always, is it? And she just passed. Okay. So, all right. Anyway. Okay. So please, don't miss this kind of procedure. Don't take it as the procedure that you are thinking. Okay. This kind of procedure mostly assumes, want to check the fetal heart rate. Okay. Acceleration when the fetus moves. Are we here? We want to know the acceleration, how the heart rate is moving once the baby moves. So we are not looking at the movement of the baby. Movement of the baby will affect the heart rate, will cause the heart rate to accelerate. I hope you know what is meant by acceleration. Just a temporal increase in the heart rate. If like, let us say during when the child is not sleeping, you are walking around and you hear something which will make you afraid, or the heart go up. Okay, or like let's take a horn, a car horn. Okay, there's a car horn. Okay, when it blows, your baby will it'll affect your baby's movement. Sometimes they move in response to that, isn't it? When they move, it affects their heart rate. Okay, the heart rate will accelerate. That's go above the baseline. Okay, that is what we are assessing. So non-stress test, that's what we are assessing, and we do mostly if that's why Sister Abigail was saying we do it to us that will assess the fetal well-being. Okay, the fetal well-being neurologically, because the brain controls that's mostly when the pregnant woman is in her third trimester, the brain controls movement. Okay, and that is when the test is performed. We just want to know how the heart rate will respond to movement. Okay, so that's all that we are assessing. So we just do it to know the well-being of it, and then the heart rate increase or this acceleration will just let us know how the baby is doing. All right, and if this test we have any condition that will compromise the baby's life, we are going to know by this. All right, so please don't miss this kind of procedure with any kind of procedure you had. I don't know the kind of procedure you had, but non-stress test, you're not looking at the movement of the baby. All right, please, okay.
Yes, please.
Okay. So that is what an acoustic stimulator is just used when sometimes the baby is not responding to movement. Just produce a sound just to let the baby move. Okay, so that you can assess if there's acceleration in the baby's or the fetus heart rate. Okay, Sister Agatha, please, you are writing on our screen. Sister Agatha, if you are all right. So non-stress test is just an invasive, non-invasive procedure. Okay, just used to assess the baby's well-being by monitoring the heartbeat and movement. So movement will have effects on once the baby moves, the heart rate will accelerate above the baseline. And that's what we are assessing. Okay, so the equipment, the real equipment or the actual equipment is the belt that we need plus the transducer. Okay, that will assess the acceleration on the screen. Okay, so that is what you should know. And with we said A is not a needed equipment or not the actual equipment for NST. Okay, that's what we should know. Once the mother can sit comfortably in a chair or can even rest in a reclining position or even on a table. So that we just want a comfortable position, but the chair is not an actual equipment that we need for this kind of procedure. Okay, and we don't need that button to press. Okay, it doesn't depend on the fetal perception. Okay, we are just monitoring the fetal heart rate in response to what uterine activity. All right, so that's what you should know. Okay.
Boss Frank, can I see the question again for a second?
That's the question. Are you okay?
I'm okay, thank you.
Question 2. The nurse is reviewing the result of a non-stress test for a pregnant client at 32 weeks of gestation. The nurse notes that the fetal heart rate baseline is 140 beats per minute with moderate variability and 2 accelerations of 15 beats per minute lasting 15 seconds each in a 20-minute period. How should the nurse interpret these findings? That is, A, a non-stress test is reactive, indicating fetal well-being. B, non-stress test is non-reactive, indicating fetal compromise. C, the non-stress test is inconclusive, requiring further testing. And D, the non-stress test is invalid, requiring a repeat test. What is your answer?
A.
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 A, reactive, indicating fetal well-being. All right.
Fetal well-being.
Thank you so much. Okay, those, you see, this non-stress test, okay, mostly we do it in a 20-minute period. All right. And the maximum that we can go is how many minutes?
30.
You tried?
40.
40. Very good. Okay, 40. So we can do a repeat after the first 20 minutes and then 40, because that is the usual sleep-wake cycle of a fetus. They can sleep as long as 40 minutes. So 40 minutes, they should wake up. That's why we do it the first 20 and the second 20. Okay, so in the first 20 minutes, we expect that the fetus should not, the heart rate should accelerate. So we do it with, and take note of this. The baseline is 140. The baseline fetal heart rate of the fetus that we are talking about is what? 140. With moderate variability. When we say moderate variability, what's the range? What's the range for moderate variability? Hello? Yes. What's the range?
15 beats per minute, at least.
15 beats per minute. That is, I mean the range for the heart rate. Okay. From above, that is above 5. That is from 6 to what?
25.
25. Very good. 6 to 25, that we call variability. When you talk of variability, you see, when we are monitoring the fetus, okay, the heart rate changes. Let me show you here so that you can fully understand what it means. Minute. Okay. Okay. Are you seeing this? Are you seeing it? Can you please see it? My screen.
No, is your question that is on the screen? No.
Okay. Let me show this one. Can you please see it now?
Yes, please.
Okay, thank you. So we know, let's assume this is the fetal heart rate that we are monitoring on the machine. Okay. So you know that fetal heart rate, it's not static. Once, let's say you go there, it changes bit per bit. So if you monitor just now and you record 160, okay, the next bit can have, let's say 150. Once it ranges between 110 and 160, that's okay. So it varies. It's not static. If you take the heart rate now, you go and check the next heart rate, it's not going to be the same heart rate. It changes. I hope you get that. So if we are having a change, or sorry, the first thing is absent variability. If there's no change, you go there, you monitor the heart rate is, let's say, 110. You go there again, you monitor 110. You go 110. There's no change, right? That is absent variability. Okay, that is undetectable. So it's not, you are not going to see a change in the amplitude on the screen. So that is undetectable or absent variability. Look at minimal. Minimal, it ranges from between 0 and what? And 5. So once it's above 0, that's obviously 1. Okay. So between that 1 to 5, a change. That is minimal. The change is just minimal. So we call it what? Minimal variability. And let me ask you, if you have variable absent variability, is it good?
No, it's not.
It's not good. Okay. That's not reassuring. Not at all. And we have moderate variability. Moderate variability. So it ranges between what, 6 to 25. So the change is between 6 to 25. Do you understand? Between 6 to 25. So as you can see, the amplitude is a bit tall, taller than the previous two. Okay, so it goes beyond 5 to 6, between 6 and 25. That is what? Moderate variability. And that's the range, the normal one that we want to see. Okay. And absent variability and those stuff, it can be that the child is not receiving oxygen. It can be hypoxia. That is happening. Okay, so if you are not seeing any change, any variability on the screen, it tells you that either the child is having hypoxia or acidosis. Okay, and for the minimal, it can be that the child is sleeping. Okay, for minimal variability, the change is very small, 1 to 5. It can be that the child is sleeping, or sometimes the mother has taken any sedative that is putting the mother to sleep and the baby as well to sleep. Okay, and we have moderate variability. That's normal. That's good. That's what the range that you want to get. If the child is active, not sleeping, that's the range that you want to get, between 6 to 25. And marked variability is above 25. Do you understand? Marked variability. So when we are doing non-stress tests, because I told you that you want to see acceleration. Once the child moves, you want to see acceleration. Once the child moves. Okay. And this one is not in connection with contraction. Are you getting it? Are you getting it? It's not in connection with what? Contraction. If contraction comes and the child moves and affects the heart rate, that is what we call what? We call that what? Hello, class.
Yes, boss man.
What do you call it? Contraction stress test. If the movement resulting in heart rate, acceleration in heart rate, is as a result of contraction, we call it contraction stress test, meaning that it is contraction which is causing stress on the fetus, resulting in what? That increase in heart rate, or resulting in that movement. Are you please okay? That is contraction stress test. But this one is non-stress. So non-stress, we are not doing anything. It's not about contraction. It's not about what? Contraction. So with absent of contraction, we want to know how the baby is doing. The well-being of the baby, okay, with what? Eventual result in what? Acceleration.
Boss man.
Yes,
Please,
please.
when is the contraction stress test done?
Contraction stress test.
Yeah.
We can do it after non-stress test. Okay, if after non-stress test, we are seeing like we are not everything is okay. You want to know whether the baby can withstand delivery, the force of labor. Okay, if the baby can withstand that, sometimes beyond 34 weeks, the mother will go and do this test. If actually the baby can respond to what? Stress of labor without developing what? Hypoxia. Because sometimes without these things being done, during contraction, during labor, some fetus can die out of hypoxia, isn't it? So once we initiate contraction, how is the baby going to respond? I hope you do understand that. So if the baby responds, the heart rate increases or decreases. That one we are going to know how the baby is going to pass through stress of labor. That's why we do contraction stress test. If neurologically everything is okay, there's enough blood flow, then the child is not hypoxic. And we do it mostly to those patients.
What is involved in that contraction test? Like the non-stress
What is involved
test?
in contraction stress test?
Yeah, you said like when you told us about the non-stress test, you told us about the screen and the transducer they use for it. But I want to know about the contraction test, the equipment they use in doing that one.
You come to that, don't worry, okay? You come to that. For now, we are discussing non-stress test. Okay. We are discussing about non-stress test, but almost the same. Okay, we come to that, don't worry. But just the difference is that one, we are inducing contraction, the other, we are not inducing contraction.
Okay, thank you.
Sister Jane.
Yes, but please,
Yes,
I want to find out about the last one, the marked viability. What did you say about it?
The marked variability, if we are monitoring, this one is just a monitor, the one that is showing on the monitor. Okay. And let's assume that let's look at the moderate one. The moderate one. Have you seen thin lines, horizontal thin lines in between? Thin
Yes,
lines.
please.
Can you see it? Can you see my arrow? This line.
It's on the marked variability. The thin
Yes.
lines, okay. The straight
I mean
ones.
the moderate. I'm using the moderate to show that you an example. Have you seen that thin line?
Yes.
Yes. So these thin lines represent the fetal heart rate, the rate. Okay. So let's assume this is this line is 140. The next line maybe 150. The next line 160. Do you get it, please? That is how the
Yes,
monitor is
please.
going to show. So if the lines, those zigzag lines that you are seeing is the change in fetal heart rate. I hope you see it. That
Yes, please.
absent, minimal, moderate, that line, that change in that amplitude that you are seeing, it goes up and down, those things. That is the fetal heart rate. Okay. And it's saying that look at absent. Okay. It just in between the baseline. That's the baseline. No change. Okay. That is a change is zero. It doesn't go above the baseline. If it's 140, just 140 that it is. It's not going above the baseline. That is absent. There's no change. It's undetectable. Okay. When we have minimal, okay, minimal is 1 to 5. So, okay, so let's assume that each line in between line is 5. So let's take this the initial one as 140. So the next line is 145. So look at moderate variability. Okay, it's just between those lines. So it can just peak to that 5 to that 5. Okay, it means that there's a minimal. So if the change in heart rate above the baseline is between 1 to 5, that's what we call minimal. And moderate, if the change in heart rate is between 6 and 25, that is what? Moderate. And with marked, the amplitude can even go beyond 3 lines. It is not showing it here, but you
It's
can
not
see
showing.
that,
Oh,
yes,
okay.
the amplitude can go above 3 lines. That is marked beyond 25. So let's assume that each line is 5. So if it's going beyond 25, that is marked variability. Sorry. Yes, marked variability.
Yes.
Have you seen it?
Oh, yes, please. I understand. But my question was, you see, for the absent one, you said that if it is recorded as absent, then it's possible that the baby is hypoxic or is acidotic. And you came to the minimal, but then the marked, I don't know if you commented on it, and I didn't get it.
No, I have not commented on marked variability. Okay.
Okay.
If you have a patient with marked variability, what it means is that with marked variability, you see that there's a very wide change. Okay, in what? In what? Wide change in what?
Fetal
The heart rate.
Fetal heart rate.
Yes. Very wide change in fetal heart rate. And if you're having wide change, it can be a whole lot of things. It can be that the cord is not receiving enough oxygen. That's why the heart rate is going up. Because if like, let's assume you are very anxious, someone is after you, running after you, want to kill you, or want to do something bad to you, what will happen to your heart rate?
It will increase.
It will go up very high, isn't it? So marked variability going above that 25, it could be that the mother is under stress or the fetus is under what? Stress. Which of course could be resulting from what? The cord. The cord not receiving enough oxygen. And we know don't let me bring it. We come to that. So, but just know that once you have marked variability, heart rate going above 25, that beyond the baseline, it could be that the mother is under stress, severe stress, or it could be that the fetus is experiencing severe hypoxia. Are you okay? Are you please okay?
Yes.
That's when it happens. Okay, so if you are experiencing it, that is mostly that. Okay, or sometimes it could be that during labor. Okay, during labor, when the fetus is responding to labor. Okay, that's the heart rate can go beyond that baseline. Right, Mr. Precious.
Yes, boss Frank, please,
Yes.
I want to understand. With the max variability, if the fetal heart rate goes beyond 25, assuming you see the normal is 110 to 120, 150. So if it was, let's say, 120, and then it gets to maybe it's beyond 25, maybe 30. If you add it, then it's still within the normal range. Is it an issue? Did you get my question?
No, come again, please.
I said, assuming the baseline was 120, and then the fetus is now
fetal baseline is
120. 120 beats, yes, per minute. Then the fetus now exhibited max variability by having like 30 beats per minute, which is above 25. If you then it will be like 150. Is it an issue? Is it a cause for concern? I'm asking. Hello?
Yes.
Hello, did you get? Yes, did you get my question?
If it becomes an issue, is 120. But can you hear me? I'm explaining. Can you hear me?
I'm not hearing you. I wasn't hearing you before.
Okay. What we are saying is that, okay, this thing is like something we have acceleration and we have variability. Acceleration is just an increase. That's a transient increase or sudden increase, like above 15 beats per minute. Okay. But which lasts mostly above for 15 seconds and then it just gets back. But with this issue that we are talking about, okay, when there is marked variability, sometimes that's why we need to assess, because it could be a whole lot of factors. That's what I said, that it could be that the fetus is responding to the labor stress, or it could be that there is acute hypoxia. All right. So when it happens like that, if we are above what's the name? If it's above the baseline, okay, 25, it means that there is, if it's beyond that, it means that there's a problem. Do you understand? Or your question is not answered?
Please, I'm not getting the variability and acceleration. What is the difference? Because I thought the variability, it means that there should be changes in the fetal heart rate, isn't it?
Yes. So acceleration, as I said, is just a sudden increase, which sometimes, for example, if the fetus wakes up, okay, if the fetus wakes up, obviously there's going to be a change, a short increase in the heart rate. Do you understand? It can be a short increase in the heart rate. But we are looking at this variability, meaning that this one is a continuous change. Okay, this one is continuous. As you can see, this one is continuous. From one point to, it goes just going. And then the change is above 25 for a long time. And if the fetus is hypoxic, it's not going to return to normal. Do you get it? But if there's no issue, and just a sudden increase, then it will come back. That's why when you take veal chop, okay, veal chop, we say that acceleration is what? Okay. Okay, acceleration is okay. When we have acceleration, just a sudden increase and just come back. There's no problem with the baby. The baby just woke up, and then once the patient wakes up, or if, let's say, there's a horn or there's a sudden noise, okay, the heart rate is just going to increase, which will sustain for about 15 seconds, and then it will just drop to the baseline. That is normal philosophy. All right, and that is normal. There's no problem. That's why we say that acceleration is okay. You have to continue to monitor the case, continue to monitor your patient, just document. There's no problem with the patient. But once you see variability, and variability, we have the one that is normal. That's no problem with the patient. And that is what? With the types of variability, which one is normal?
Moderate.
Moderate variable.
Do you get it? So if you are going beyond 25, let's assume that you have your baseline is 110. Okay, baseline is 110. And we are going. Mr. Jen, are you asking a question, please?
Yes, please. But you finish what you are saying. Maybe you would answer my question.
Okay. All right. So if we are saying that for marked variability, we are going above what? 25. So let's assume that the baseline for the fetus is 140. Okay. And we are having a change of, let's assume, between the range is between 110 and 170. That calls for alarm. Okay, the change is so wide because the baseline for the fetus, we were recording around 140. But just suddenly, it has dropped to, let's say, 110, or it has increased to, let's say, 170. What's the difference? What's the difference? 30. 30. If it happens like that and it just continues like that, okay, because if it just acceleration, it will just come back to be normal. But if it is just marked variability, that marked, because it's going to change and it's going to continuous. It will be continuous. Okay, and if it happens like that, then we have to what? Assess the patient. There's a problem. Do you please understand now?
Yes.
Yes. So if, let's assume 140 and suddenly 130, between 130, then it goes up 170. So it's not staying at one place. That's the difference between, that's acceleration is just going up, but variability can go up and come down. The difference we are looking at between above 25. That variability changes. So it can go up, it can also go down. Okay, so it can go below, let's assume 140. So if, let's say, it changes, mark variability is around 30. So it can go below as low as what? 110, isn't it? And it can go as high as what? 170. That's not usual. There's a problem. Do you understand? But if it is going up, let's say the baseline is 140, and it goes up to, let's assume 170. 170, and then it's sustained for about 15 seconds, 20 seconds, and it's come down. That is acceleration. Acceleration means going up. By variability, it goes up and down, goes up and down. Do you understand?
Yes.
All right, Sister Jane.
But yes, so I want to find out with what you are saying. I just want to be sure it means that we know the normal fetal heart rate is 110 to 160. So let's say this person has a base, or the fetus has a baseline of 130 beats per minute, and then this fetus is having marked variability where it can go up to 160, it comes down to maybe 110, it goes up to like 151, those things. It means that though we are in the normal range of fetal heart rate, if we are measuring on a normal day, because the baseline is 130 and there is variability going above 25, it means that this fetus needs to be assessed because
it's in a serious condition. Yes.
Thank you. I now understand.
The child is in serious condition because the baseline is around 140. And that if there's a change, the change shouldn't even be more than 25. That's that's moderate. So if we're having a change and it's between 6 and 25, that's perfect. That's okay. There's no problem. But if the change is above, for example, if the baseline is 110 and you go and check, and then it's around 150. How many difference?
40.
Isn't it? So
yes,
from 110 to 140 is 80. You see the thing? The change is so wide, more than 25. That's a problem. Are you okay, please?
Yes, please.
Yes,
okay.
Please.
So that's what we are referring to. So, and if you are monitoring this change, the variability within more than let's say for 10 minutes, there's that change. That's a problem. Okay, so please let's monitor our fetal heart rate. Very, very important. If you are having a change, there's a sudden change. If just going up and comes down, that's acceleration. That's okay. Acceleration, okay. But marked variability, please, is not okay. It's a problem. All right. I hope there's no question again. You can continue, right?
Boss Frank, please, if mark 3 is a problem, the absent 3 is a problem, right? Hello. Boss Frank.
Yes, please.
Please, I'm asking that if mark is a problem, then absent 3 is a problem. Or absence a minimal.
Yeah.
Your network is frustrating. I can't hear anything.
But I think that absent, he said the baby could be sleeping.
Okay. And the minimal 2.
And the
Please.
minimal is normal, the normal level. That is
No,
how.
No.
He
It's more
said
than
with
the
the
normal one.
absent, the child, the fetus could be hypoxic or acidotic. But with the minimal, it could mean that the child is sleeping or the mother has taken some sedation. That is causing the child to probably sleep or is affecting the child.
Okay, thank you.
So the
Thank
moderate
you.
is what is
The
normal.
normal. And the mark is the abnormal one when it's above 25. Okay.
Yes, mother or child is in stress.
Yeah. Okay. Thank you.
Yeah, hello. Can you please hear me?
Yes, what's wrong?
Sorry, my network went off. Are you okay with what we are discussing, please?
Yes, sir.
Boss
right.
Frank,
Yes, please.
please, last question.
Okay.
So with what you have explained, it means that the variability, you are talking about accelerations, right?
Variability is not acceleration.
It's acceleration and deceleration.
Yes, just going up and down, just like that.
Okay. So the change you are talking about, is it just, so we have a baseline. If it's going up and down, does it mean that the fetal heart rate could also reduce to by 6 to 25 and it's normal?
Yes, if it reduces and it's within 6 and 25, that's normal.
And if it increases and it is within 6 and 25, it's normal.
Yes.
Thank you. I get it now.
Is that Precious?
Yes,
Or the
boss.
same person?
Please, thank you. So I want to understand the absence variability. What's the intervention? What are you supposed to do if you should see that on the monitor?
Okay. What did I say absent variability is? What's the cause?
You said fetus could be hypoxic or acidotic, something
If
like that.
your fetus is hypoxic, what can we do?
Try
What
and
can we
get
do?
oxygen to the fetus.
You can change position. Lion, we know lion.
Yeah, lion feet, something like that.
You can
Oh,
lie. Okay, if it's infusion, maybe the child is not getting enough blood flow. So you have to increase your infusion. Okay, you can give oxygen. All right, you can notify your healthcare provider. Do you get it, please?
Yeah.
As simple as ABCD.
Okay.
I hope it's not difficult.
No, thank you.
All right. So this question obviously is reactive. Okay. So I said we monitor for 40 minutes, but first of all, we assume the 20 minutes first. We do the 20 minutes first. Okay. And with that 20 minutes, you should have acceleration. And this for this one, it's non-stress test. It has nothing to do with contraction. Non-stress. Okay. And the baseline was 140 with moderate variability. And we know moderate is what? Good. 6 to 25. A change between 6 and 25 is okay. That's good. All right. And 2 accelerations. 15 bits lasting 15 seconds. Because acceleration just going up. Okay. And it goes up for about what? 15 bits above the baseline, which is 140 now. and then it lasted for what? 15 seconds. So let's assume 155, around 155, and then 15 seconds, it came down. All right. And that is what? A reactive. And when we have two main interpretations, okay, that's the method interpretation. It's either reactive or what? Non-reactive or non-stress test. Either reactive or non-reactive. Please take note. All right. You can move forward. So answer is reactive. Okay, because a reactive means that the fetal heart rate increases by at least 15, lasting 15 seconds, twice or more in 20-minute period. So when in a 20-minute period, we are monitoring the patient, and then there were increases of what? 15 beats per minute. For it occurred twice within that 20 minutes. That's reactive. And shows that the fetus is what? Healthy, getting enough oxygen. And non-reactive is just opposite if it's not happening this way. Okay? And we say inconclusive means that it's unclear, or you don't have enough data to support your procedure. Okay? Yes. And invalid means that it wasn't performed correctly. All right? So that is, so no. The normal ranges for fetal heart rates are 110 to 160 per minute with moderate variability. All right? 15 to 25 beats per minute and no deceleration. So this one we are having no deceleration. All right. The nurse is performing a non-stress test for a pregnant client at 36 weeks of gestation who report decreased fetal movement. The nurse observed that the fetal heart rate baseline is 120 beats per minute with minimal variability. Take note of those adjectives. Minimal variability and no acceleration in 20-minute period. What should we do next? A. Offer the client a snack or juice to stimulate the fetal activity. Apply an acoustic stimulator to elicit fetal movement. Stop the test and notify the provider. Extend the test for another 20 minutes. What are you going to do?
While the client is snack or juice to stimulate fetal activity.
Yes. Offer the client snack or juice to stimulate fetal activity. All right. Any other?
B or D.
Apply acoustic stimulator to elicit fetal movement. All right. Any other?
D. Extend the test for another 20 minutes.
Extend the test for another 20 minutes. Okay.
I think it's D.
You think it's D?
D.
All right.
D.
D, right?
It
Okay.
could also be D because you told us that you can do the test again in 20 minutes.
So it said it could also be D. So what was your initial answer?
It was B.
D.
Yes.
English, you can choose two answers. So choose one.
So I would also go for B.
B. Okay.
Yes, B for boy.
We shall see.
D.
All right. Let's analyze the question. Yes, please.
Sir, please, the view chop, can you refresh our memory on it again, please?
Which one?
I think that would also help. The view chop. Can you please refresh our memory on it again? Yes, I think it would also help.
Okay. The whole thing is about variability, deceleration, acceleration. This fetal heart rate monitoring that we are talking about. Okay. So we are looking at variability. And if for variability is good because for heart rate to remain the same is a problem. So when you say variability means that there should be a change, either falling, decreasing, or going increasing, the fetal heart rate. And that's good. So that's the V, variability. And its acronym, equivalent acronym is what? CHOP. The C. So the first acronym to first acronym. The V for V and the C for CHOP, what? Continual what? Monitoring. So variability is okay unless the question specifies that there is what? Marked variability. But if just variability is good because we know there should be a variability. It can't be static like that. The heart rate can be static. Are you okay?
Yes, sir. Yes, sir, please.
All
Yeah,
right.
okay.
So, and we are saying that for we this fetal monitoring, we are looking at variability, we are looking at deceleration, we are looking at what? Acceleration. Are you okay? And we are looking at the intervention that we are going to talk about. So that is variability. When it comes to deceleration, we have types of deceleration. The heart rate can decelerate. Decelerate means what? Coming down, isn't it? Yes. So deceleration means coming down. And deceleration, we have different types. One type is called early. Another type is called what? Variable. And the last type is called what? Late. Before you can understand this, I'll always use this as an example. When a baby is being born, which part comes first? As normal labor, which one comes first?
The head.
The head.
The head.
The head.
So the head means that it is early deceleration.
Early deceleration.
Head. Early deceleration. So from the head, and then umbilicus, and then what's the other one? The placenta. Between umbilicus and the placenta, which comes second? Which comes second in birth?
Umbilicus.
And which comes last?
Placenta.
Placenta. So when we see placental insufficiency, that is late, because placenta comes last, late. So late decel, the problem is placenta. And the middle one, which is the umbilicus. So when we have variable decel, the problem is umbilicus. When we have early decel, the problem is what? The head. The fetal head. When we have variable decel, which comes in the middle, the problem is what? The umbilicus. And the which comes last, which is the placenta. So we have late decel. The problem is what?
The placenta.
Placenta. So early decel, when there's contraction, because of vagal stimulation, when there's contraction, the heart rate will go down. Whenever there's contraction and it compressing the head, the fetus, the heart rate will have to what? Go down. So that decelerates. So when the heart rate goes down during contraction, it occurs at the same time. So once contraction starts, you see the heart rate dropping. So you have to monitor. So that's why we monitor on the pathograph. We monitor. Let me show you how it is so that you can love this. A minute, Okay. So okay. Let me type to you. Okay. Let me count this way. All right, let me show you this so that you understand. Can you see my screen, please?
Yes.
Can you?
Yes, please.
You can see the drawing, right?
Yes, please.
Okay. So we have acceleration, we have variable, and those stuff. Okay. Let's look at let me show you. I'm coming. Let me show you okay. Let's take this one. All right. So whenever you look at the graph, this is what you are going to see. The button one is considered what? Uterine contraction. Have you seen the bottom line? That's the uterine contraction. Okay. And the lines above is what? The fetal heart rate. Are you okay? The lines above is fetal heart rate. So when you see the graph, you're going to see two lines. Two lines. One is uterine contraction, and the top one is what? Fetal heart rate. So let's assume the fetal contraction. Just look on the fetal contraction, uterine contraction, sorry. When you look at uterine contraction, you can see it goes up and down, right? So the up indicates that there's what? Contraction ongoing. And it goes to a peak. That's the highest point. Okay. When it's dropping, that means, please mute up if you're not talking, please. If you're not talking, please mute up. So if you see the deceleration, types of deceleration here, if you look at the contraction, okay, you see that when you check the heart rate, you can see that it was just going straight line and then it came down, right? Can you see that it came down? The first one, look at the late decel. I'm talking about the late decel. Have you seen it? It was just going straight line, and then it came down. Can you see it?
Yes, please.
So coming down happened after. Late means you are late. You came late. So late decel means that it came after contraction has ended. Contraction has reached its peak. When contraction was just coming down, then you could see that the heart rate was also dropping. That is late decel. When contraction reaches its peak and it starts coming down, and you see that the heart rate is also coming down. That's not the heart rate should come down, because the heart rate, you should come down once contraction has reached its peak. That's when you should come down. But if contraction has already occurred and it just immediate, just before it's just coming down, that's when the heart rate, you are also coming down. That is, you came late after contraction has occurred. Do you understand, please? Do you?
Yes.
Look at this. The bottom one is what? Uterine contraction. And look at the red arrow. That's where the heart rate dropped. When did it happen? After contraction has ended. Right? When contraction was ongoing, there was no change in the fetal heart rate. But once contraction has ended, once it reaches its peak, it starts coming down. So when it starts coming down, when contraction starts coming down, that is when the heart rate also starts dropping. That means it came late. Do you understand? Do you understand, please?
Yes, please. Yes, please.
And whenever you are late, according to childbirth, which comes late, that is what? placenta. So late deceleration is the problem of placenta. It means that the placenta is not supplying enough blood to the fetus. That's the whole problem. It could be that the mother is experiencing preeclampsia. The mother is having hypotension, because hypotension, the blood volume is so low that it's not able to pump enough blood. Or the mother is experiencing hypertension. Hypertension, the blood vessels are constricted. All right? The mother is having diabetes. So the mother can have any problem that will compromise placenta blood flow to the fetus, and it heart rate of the fetus will start coming down immediately contraction has ended. Contraction has reached its peak. So once contraction reaches its peak, when it starts coming down, the contraction is coming down. That is when the heart rate is coming down. So it means that you came late, and that is late deceleration. Are you please okay?
Yes,
Let's go to early deceleration. Early deceleration. That's the next one. Look at where contraction is. The peak of contraction. You are looking at the peak of contraction. That's the hill. The hill you are seeing. Okay. The peak of contraction, trace it to where the heart rate started decreasing. Okay. It means that once the peak, we are having a peak of contraction. That's where we are having the lowest point of what? Decrease in heart rate.
Okay.
It means that contraction and decrease of heart rate occurred at the same time. Once contractions start coming, that's when the heart rate also starts dropping. When contraction reaches its peak, that's when the heart rate reaches its lowest point. Once contraction is resolving, that's when the heart rate also accelerating. That's going up to baseline. That is what we call early decel. So early decel occurs at the same time, as early as possible. Once the contraction is there, you can see what? Deceleration. So it came early. So you can see that it has U shape. This one has U shape, and the other one is having what? Let's say assume N shape. Okay. So the bottom and the peak occurs at the same time. Are you please okay? With early. Early means that it occurred at the same time. So it mirrors, deceleration mirrors maternal contraction. It occurs at the same time. One contraction is ongoing, that's why you see the heart rate dropping. Contraction reaches its highest point, that's why you see the heart rate reaching its lowest point. Once contraction is resolving, that's why you see the heart rate also going up to the baseline. So that is what we call early decel. And for variable decel, that one, you have no formula. Whether there's contraction or no contraction, it can decrease, it can increase at any point in time. There's no formula. Look at the middle one. Okay, look at the first decrease. The first decrease, it almost similar to where the contraction was occurring. But look at the second one, the second decrease of the fetal heart rate. I'm looking at the, we are talking about the variable decel, okay? Look at where it's closer to C, where they've written C. Look at the second decrease. There was no contraction, right? But it decreased. So when you take the decreasing heart rate, it doesn't mirror anything. It doesn't have a pattern. It can decrease, it can go up at any point in time. That's variable. It varies. It's not something that is following a pattern. Are you please okay? And we are saying that, and you see that the first one on top, that's acceleration. It just goes up, okay? And at a point in time, it will go up. At a point in time, it will go up. So that's normal, okay? That's acceleration. And we are saying that early decel means that the head comes first, head compression. And when there's head compression and the heart rate is decreasing, that's normal. That's normal physiology. Whenever there's contraction, compressing the head, the uterus muscle compressing the head, obviously there's going to be what? A decrease in heart rate from vagal stimulation. And that is okay. There's no problem with it. So that's why in veal chop, the yi in veal represent what? Early what? Represent what? The yi in veal represent what?
Early deceleration.
Early deceleration. And when you go to the chop, the second one, which is the H, represent what? Head compression. Are you okay? And then the A in veal is spelled V-E-A-L. The A in veal represent what? Acceleration. Put the third variable in what? Veal. When you go to chop, the third one is what? O, isn't it? And that is represent what? Okay. That's why acceleration is considered okay. There's no problem. Acceleration, we have to, there should be acceleration. There should be variability. That's okay. There's no problem. And the last L in the veal represent what? Late deceleration. And the chop, the last variable is what? P, which represent what? Placental insufficiency. So that is it. I hope it's okay. And it's not easy, it's difficult, right?
Yes, please. It's okay.
So just consider fetal birth. Which one comes first? The head. So that's early. Which one comes middle?
Middle.
Cord. Which is variable. Which one comes last? That's placenta. So late deceleration represent placental insufficiency. Variable represent cord compression.
Cord compression.
Okay, and cord is compression. Either there's a nuchal cord. That it can be that the child has my English is gone. The child has encircled the neck with what? The cord.
Cord around neck.
Yes, cord around neck. And that is the cord is being compressed. Or sometimes it can be that if we are having oligohydramnios. Oligohydramnios. Okay, I hope you know oligohydramnios. Oligo.
Yes, oligo.
Yes.
In small quantity.
Yes, just a little movement.
Small amniotic fluid.
Yes. Oligo means what? Less. Okay, reduced. So just small amount of fluid in that the fetus is swimming. So just a small movement, the child can just the cord can just go around the child, the fetus, and that one can compress the cord. Okay, so oligohydramnios can be a risk factor for compression. I hope we are okay. Back to our question. So
first, please, I wanted to ask something small.
All right.
So please, for the acceleration, you said it is okay. So I just wanted to find out that if there is too much acceleration, can we link it to marked variability, as in where you said, because sometimes variability could come down, it could also go up. As in when you said maybe marked variability, there's uncertainty whether it is unclear whether it is good or not good. So I just wanted to find out that if there is too much acceleration, can we link it to marked variability in that it has exceeded maybe the 160? Could there be acceleration which can exceed the 160?
If acceleration, yes. Acceleration, just we have parameters that will indicate that it's acceleration. Just know that
Right.
acceleration, we have
Right.
an increase of greater or equal to what 15 beats per minute, which is what lasting for more than 15 seconds, equal or more than 15 seconds. So supposing we have baseline heart rate to be 130, okay, and we have a change, an increase of 15. Let's assume 20, because it could be 15. The minimum is 15. So 15 or more. Okay, for 15 seconds. So 15 seconds, for 15 good seconds, the heart rate is still high, above the 130. Let's assume the baseline is 130. For 15 seconds or for 20 seconds, we are still having heart rate to be 120. So let's say baseline is 130, an increase of an increase of 20 would be what? 150. So for 15 good seconds, we're having within 150, 150, 150, or 150 and above. That's between that. Okay. So if we're having that, but it should be less than 2 minutes. Because if the child wakes up or there's a sudden noise, and then the child begin to vibrate or shakes, there's going to be that sustained increase in heart rate. But that should last less than 2 minutes. If it's lasting less than 2 minutes, that is okay. That's what we call acceleration. So acceleration shouldn't be more than what? 2 minutes in duration. But it can be more than 15 seconds. 15 seconds or more is okay, but less than 2 minutes. All right. So to your question, when we're having acceleration, let's assume 20, a change of 20, or let's assume 30. Okay, 30 beats per minute above the baseline, 30 beats per minute. So which is now 160. Okay, from 130 to 160, which is 30 beats above the baseline. And it's lasting for 1 minute. That is still acceleration. But variability comes, marked variability comes in when there is increase and decrease. It's not only increase that we consider to be, what's the name? Variability. The moment we term that as variability, that means there should be a drop and increase in the fetal heart rate. We don't consider acceleration. There's no acceleration which is going to be sustained for quite long, unless there is variability. That one, if the fetal is having hypoxia, we are going to see variability. We are not going to see that sustained heart rate for quite long. We are going to see variability. Are you please okay?
Yes, please. I'm okay. Thank you.
All right. Sister Ruth.
Please, the variability, is it good or is still is bad? If it is marked variability, is it good or bad?
Variability in general, if there's no identifier, we are not identifying it by either marked, minimal, absent, or moderate. You know, if it has that identifier, only moderate is good. But if in general that we say variability is good because we should have a change in the fetal heart rate. The fetal heart rate can't be the same number. It can be 130. Always go and check 130. Those who have been doing what's the name? Free charts. 130. The next minute 130. They are lying. Okay. We should have that variable. Okay. That variability, if it's just variability, that's normal. That's okay. That's why in view chop, the V represent what? Variability. And when we go to the chop, C represent what? Continue to what? Monitor. I believe it's okay. So when it's not, there's no identifier or there's no describing it. Just stick with the kind of variability that they're talking about. Are you okay, please?
Yes, sir. Thank you.
Are you okay?
Yes, sir.
Yeah, we
Thank
are.
you. Yeah, okay.
Boss fine. Please, you said
Are you
in
okay,
view
please?
of
Yes, we are good.
Mm-hmm.
boss fine, you said in view of the C is
Yeah, someone is
continuous
asking.
monitor.
Mm-hmm.
I'm not getting that one.
You're not getting what?
The
Sorry.
virtual.
Which is variable deceleration. Variable deceleration, which is when
Chord
yes.
compression.
So when we look
Yeah.
at variable deceleration, okay, variable deceleration. That one, if we say variable deceleration, if you specify, because that is not types of variability. That is types of what? Deceleration. That is types of what? Deceleration. So when you say variable decel, that one is what? Chord compression. But when it comes to variability itself, that we continue to monitor. Are you okay? Unless we specify, unless they specify that moderate, minimal, absent, or marked. Are you please okay?
Okay, sir. Thank you.
All right. With absence of question, let's go to question 3. So yes, so obviously with this one, the nurse observed that the fetal heart rate baseline is 120 beats per minute. So we have a baseline of 120 with minimal variability. So with minimal variability, what does it indicate? Minimal. What does it indicate? It's telling us that the fetus is
The
what?
child is sleeping.
It's sleeping, or the mother is taking.
Yes, it could be that the child is sleeping. Yes, or the mother has taken anything straight. Okay, with no acceleration in 20 minutes, period. That's we did the non-stress test. Because non-stress test is just an acceleration, heart rate, increase in heart rate. So, but there's no acceleration. Okay, because of what? Minimal variability. And there's no acceleration. No acceleration is okay. Because no acceleration means that the child is, unless acceleration comes if the child is awake or the child is like there's a sudden noise or something like that, or the mother is fearful or something like that. Okay, that is no adrenaline, the adrenaline stimulation, those stuff. Okay, so this one, it could be that the child is sleeping per our description here. So what do we do next? So if you want to do another test for 20 minutes, how many minutes did I say the child can sleep? As long as what?
40 minutes.
40 minutes.
For 40 minutes.
So the first 20, you are not seeing the child is sleeping. The second 20, the child can be sleeping. So you are not going to see any change. So with the child sleeping, you have to what? Or the mother is either sleeping or the mother is just down, not moving. So or the child is even hungry. Okay, so we have to what? Offer something for the patient to eat. All right. So that's what we do. When you do
Already done with
acoustic
only 20 minutes.
stimulation, is that?
We've already done with the first 20 minutes. So we've not done the
The
second
first 20
20
minutes, which is, yes, we have not done the second 20 minutes, but
so
we have to know that there are indications to do the next 20 minutes. Okay, you should ask yourself, why do we have to do a repeat? Let me ask the class, why do we do a repeat? What will authenticate a repeat?
If there's no
Yes.
increase
Respond to the first.
If there's no what?
Respond to the first test.
if the child didn't respond to the first test, right?
Yeah.
Yes. And it just, with the first test, if the child didn't respond, we have to do another 20 minutes. But
Okay.
before that,
This one is good.
before that, you have to, because when you don't do intervene, when you don't do anything, and you go ahead and do the second 20 minutes, you're not going to yield any results.
Yeah, that's true.
So how would you know that the child is sleeping? So do something to stimulate the child, or do something to stimulate the mother. Once you do that and do the second 20 minutes, it could be that the problem is coming from either oxygen issue or something like that. So do something before you do the second test. Or you've done the first thing and you've ruled out anything that will compromise fetal well-being before you go ahead and do the repeat. Are you okay? Yes.
So,
Sister
but Frank, what is the answer?
It's Ella.
Yeah.
Boss Frank.
Sister,
Boss Frank, please, I want to find out. Can I be heard, please? Yes. I just want to find out. I'm new to this, so maybe my question might not be bad. I want to know, is there a reason why the maximum you can have this fetal variability test or non-stress test done is 40 minutes and not more than that?
Anybody here? Sister Jane?
Yes, Boss Frank.
Sir.
Can you please? Yes, please. I didn't hear you well. Or did...
I was asking that is there a reason why the maximum period you can have this non-stress test done is 40 minutes and not more than that?
Okay. I think someone want to answer, right?
Yes, please.
Mm-hmm.
Sir, please, you mentioned that the maximum time the fetus can sleep is for just 40 minutes.
Mm-hmm. So when you do the
Yes,
first
so
20, it means
yes,
it could be that the child is sleeping. So when we have
the child is sleeping.
yes, so we have to do a repeat of 20 minutes. 20-minute
A
period.
repeat of 20
After
minutes.
that 40-minute period, if the child is sleeping, by all means the child should wake up. So the child can sleep as long as 40 minutes.
If all things being equal, the child should
Yes, can sleep 40 minutes. The child can sleep the whole for 1 hour. No, they sleep intermittently. Okay, but for one cycle, the child can sleep as long as 40 minutes. Okay. All right.
Okay,
Yes, please.
so but please, does it mean that for instance, with this question, it means let's say the child was sleeping, that is why it's read that way. It means that you have to do something to stimulate the child to wake up before the second 20 minutes is done.
Yes,
Am I right?
we have to rule out. Okay, you have to know, because the first 20 minutes, let's assume the child is sleeping, or the child is hypoxic, because the child is hypoglycemic. If you are hypoglycemic, I hope your activities go down, right? Your activity, they go down. All right, so the same thing is happening. When activity is going down, it can be that, so when we have heart rates, because according to the question, we are having no acceleration with minimal variability. That's the word. Minimal variability with no acceleration. And you know what minimal variability can indicate? It can indicate that the fetus is what? Sleeping. Or it can indicate that the mother is hungry, which is affecting the child. The child too is hungry. Okay. So after the first 20 minutes, do something before you do the second one. Because if you offer the child the client snack, okay, and you do, let's assume that the child is, so it could be that the child is hungry. So we've offered the client snack. Before you go ahead and do the repeat. So if you do repeat and you're getting the same result, then you can safely conclude that this test is purely non-reactive. Do you understand?
Yes, please. I was about to ask that if the child sleeps for 40 minutes and you have done the first 20 and this is the results you are getting, then you can wait for extra 20 minutes to pass, then you do the second one. But then
No,
I
you are
think,
not waiting for extra 20 minutes.
yeah, I understand now. It means that if the child is hypoxic or there is something going on and you wait for that length of time, it could affect the baby. So you have to intervene and then recheck.
Yes. So with this one, we can either do delivery. You can either do delivery if other parameters indicate that maybe because once we have minimal variability, it means that the heart rate is there. Okay, so we can do quick delivery. All right. So this one will help us to know what is happening with the child. That's why we said it assesses the fetal well-being. So once you know that there's after 40 minutes everything is done, but we're still having non-reactive, go ahead and do your delivery. Are you please okay? All right. So basically, that is that. So non-stress measures fetal heart rate and reaction to movement. So fetal heart rate and then reaction to what? Movement. So perform to make sure that the fetal is healthy and getting enough oxygen. So as I said, we have reactive, non-reactive. Reactive means that the fetal heart rate increased by, so that's why whenever we mention NST, we do combine with what? Acceleration. So it goes with acceleration. So whenever you have NST, non-stress test, we are looking at fetal heart rate acceleration. And that acceleration, we've said that we should have at least 15 beats per minute for at least 15 seconds. All right? In that 20-minute period of your non-stress test examination. Are you please okay? So non-stress test always goes with what? Acceleration. Fetal heart rate acceleration. That's what we are monitoring. Okay. All right. And applying acoustic or stimulator to elicit the heart rate is not recommended. Okay. So you don't have to ring a bell to stimulate no. The child can't sleep to that extent of before you can ring a bell. You have to do because there's minimal variability. You have to know what minimal variability represents before you know what to do. Okay, and stopping the test and notifying the provider is not necessary unless you have fetal compromise. Because this one we are not having fetal compromise because there's minimal variability. Okay, you don't have severe or late deceleration. Late deceleration cause for concern because late deceleration we know is placenta late. Okay, variable we know is what? Variable is what?
Cord
From what?
compression.
The
Cord.
cord. Yes, very good. So extending this one wouldn't yield any results because we have not done anything because the child is sleeping or whatever. And nurse is teaching a pregnant client about purpose and procedure of non-stress test. Which of the following statement by the client indicate a need for further teaching? The test will measure how my baby heart rate changes when he moves. The test will take at least 20 minutes, but it may take longer. The test will involve placing 2 belts around my abdomen. The test will require me to lie on my back for the duration of the test. The answer is what?
Is D.
You saw it. It's
Wow.
D. All right. So you don't lie at the back. Why? Because for pregnant women, lying at the back is contraindicated. You know that? Mm-hmm. Yes, for orthostatic hypotension purposes. All right. The nurse is evaluating the result of non-stress test of a pregnant client at 34 weeks of gestation who has gestational diabetes. The nurse notes that the fetal heart rate baseline is 115. The baseline is 115 with moderate variability, and 3 acceleration within 20 minutes, lasting for 20 seconds each in 10-minute period. How should the nurse document these findings? Reactive, non-reactive, positive, negative. Which one?
Positive. Reactive.
Positive.
Reactive.
Reactive. Okay. I said you don't have positive. We have reactive and non-reactive. Positive and negative, we use them in where? Contraction. Stress test. And contraction stress test, between negative and positive, which one is good?
Negative.
Negative. Hello? Are you okay? Between positive and negative. Negative is good. Okay?
Yeah.
All right. So we don't have positive stress test, negative stress test. You only have reactive, non-reactive. And next is, we have 2 minutes, 2 questions more. So let's quickly finish with them. A nurse is caring for a client who is undergoing an oxytocin infusion for induction. The nurse notices that the fetal heart rate shows pattern of late decel, which is placenta, which are deceleration that begin after, because late it came after the peak of contraction and return to the baseline after the contraction ends. What is the most likely cause of this deceleration?
Placenta.
Fetal heart rate, fetal heart head compression.
C.
No, C.
C.
Placenta is okay.
C. Joe placenta.
It's cheap. It's cheap. All right. The nurse is assessing a client who is in labor and has meconium stained amniotic fluid. The nurse observed variable decel on the electronic fetal monitoring tracing, which are deceleration that have an abrupt onset and vary in shape, vary in duration, and degree of fall below the baseline fetal heart rate. What is the most appropriate nurse intervention for this situation? Reposition the client to improve placental blood flow, administer oxygen to the client to increase fetal oxidation, prepare for amniotic infusion to dilute the meconium and relieve the cord compression, notify the provider and prepare for emergency CS. Yes?
D.
Reposition.
Reposition. Okay.
G.
Hey, the answer is there. No one is mentioned. Can you see that? Variable decel is from where?
Cord compression.
Hey, my people.
Let's see, cord compression.
Yo. Variable decel. We just noticed that variable decel is from what?
Cord compression.
Cord compression.
And you want the B sound good to your ears. The D sound good to your ears. Please. I just emphasize that. That is variable. Where is it? Yes, variable decel. Variable decel. Please read the question. Variable. So variable, as I said, could be what? Cord compression. Of which I told you oligo can be a factor, isn't it? Oligo.
Please,
There.
Boss Frank.
Yes, please.
Okay, what of the meconium stained fluid, amniotic fluid? I thought
Yes.
it shows the child is in distress.
A child is what?
Severe distress.
It's in distress.
The nurse observed variable decel on this, which are deceleration that have abrupt onset and degrees of force and baseline. What's the appropriate intervention for this? So the client is in labor and has meconium stained amniotic fluid. He has meconium stained amniotic fluid, and you are seeing variable decel.
Sir, please, I have a
Yes, please.
so was saying, what will you do first? What would have been the answer?
What will you do first? It says that hold me. Mr. Homie, please help us by muting yourself, okay? Thank you. Yes. What was the question, Bo?
If the question had said, what will you do first? Or what should be done first? What would have been the answer?
Okay. So, when the question asks you first, it's trying to talk about what? What is it trying to talk about or indicate? The steps involved, isn't it? The steps. First means steps. I hope you are hearing me.
Yeah.
Yes. And the child is having meconium stained amniotic fluid. What is there indication that the child is in severe distress? Hello?
Hello.
Is there any indication that the child is in severe distress?
Yes.
Oh?
Is there any indication that the child is in severe distress?
Yes.
Which is?
Meconium stain.
Does it indicate severe distress?
Variable decel.
Does it indicate severe distress?
Yes. Oh?
Okay.
The child passed the first poop in the uterus.
Sister Inake, please, are you talking to us?
Yes.
What were you saying? You didn't hear, please.
I was saying that meconium stain shows that the child already passed the first poop in the uterus. The child is in distress.
The child is in distress. Okay.
Yes.
All right.
Actually, meconium stains indicate fetal distress.
Meconium stain indicates fetal distress. Okay. So, in this case, we have meconium stain there and having what? Variable decel, which the two will tell us that the child is in distress. If the question is asking you what you are going to do first, all right? Obviously, once the child is in distress, having meconium stain and having variable decel, you have to prepare for emergencies. Notify your healthcare provider. Because before you even prepare for amniotic fluid, amnion infusion, it has to be, and then it says prepare for amnion infusion to dilute the meconium and relieve the cord compression. All right. So you know that with this one, if the child is in this state and the question is asking you the first thing to do, the first thing, obviously, the answer would be what? To notify your healthcare provider and prepare for emergency CS. That's the first thing to do. Because once the child, that's the only way, that's the to
Fastest way.
yes, to save
Life.
this child. So that's the first thing to do. Are you please okay? Are you okay? So please know what the question is asking you and know what to answer. All right. Okay. Let's go to the last one, which is 8. A nurse is performing a non-stress test for a client who is at 32 weeks of gestation. Before that, when do we perform non-stress tests? Okay, a question to as well. I'll
Can I answer?
Wait.
I know that the hello. So you asked a question
all
that
right,
when did they
let's go.
perform?
Let's go. Okay, the nurse observed that the fetal. You said what?
No, sir, I thought you asked the question like when is non-stress test performed. I thought you were asking the
When is that?
question.
Yeah, I asked.
Okay. I know that I heard from you that is performed to assess placental function and oxygenation of the fetus.
From 36 weeks.
Weeks and above.
From
It is
30,
from 36 weeks and above. Okay.
35th.
6.
I'm not hearing you well.
I said from 36 weeks for no stress test.
No.
Okay.
32.
All right, we'll come to that. Which of the following tests should the nurse anticipate to be ordered next for this client? Select order, apply. Biophysical profile, contraction stress test, umbilical artery, Doppler velocimetry, amniocentesis, fetal kick count. What are your answers? The child has intrauterine growth restriction, and you are observing that the heart rate does not accelerate after 20 minutes. Okay, so what are you going to do?
B.
Mhm.
B. B. B.
B.
Select all that apply.
And select all that apply.
After 2 can only be 1.
Mhm. So the answers are what?
A,
Mhm.
A, B, C, D.
A, B, C, D. Okay, A, B, C, D. Why are you doing contraction stress test if the child is not moving? The heart rate is not moving. Even the non-stress test, even the non-stress test, the child is not, we are not having heart rate. We are not having acceleration. How much more contraction? Do you get my point? Hmm?
Come again.
So the answers are out. You have to do. Yes, please.
I thought the contraction stress test is done if the outcome of the non-stress test is not as reassuring, which is what is happening in the question.
Which is happening in the question?
Yes.
Okay, let's see. Any other? All right. So the answers are A and C. Okay, you have to do biophysical profile and do artery velocimetry. We have to measure the velocity in the artery, umbilical artery. Okay. So we are saying which one? Which is B. Let's see, especially at when do we do contraction stress test? When do we do contraction stress test?
When the non-stress
That's a
test
trick.
is
And at what age? What weeks?
uh,
From
All
37.
right. So the
It is.
answers are A and C. Okay. So we are going to end here. God willing, next week we are going to go into it deeper. All right, into maternal nursing. Thank you all for
So,
joining.
surface no need. Asem.
This one just surface, okay. But you know it's not difficult. Do you know is it difficult? It's not.
Wow.
It's not
It
difficult
is.
at all. Just know what you are saying. Just know, read the question law. You know your way out. Okay. All right. If there's no question